So welcome everybody to Health Together, previously known as Maternal and Infant Health Canada's educational webinar series. Today's webinar is called Homemade Orthotics for Foot and Knee Problems, a functional approach with Dr. Hélène Bertrand. Before I introduce Dr. Bertrand, just for those of you who are tuning in for the first time, and those of you who aren't know my spiel, but Maternal and Infant Health Canada, which has been really growing and expanding both in its reach and its community, as well as its focus. And as such, we needed a new name. And we needed something that reflected that. And so after much thought and discussion, we came up with Health Together. And so we're very excited to share our new name and with such an incredible topic to start off our new journey. We're a global public health collaboration working to improve the health of women and children around the world while seeking equity-driven solutions to a more sustainable world. Our pillars include education, research, and innovation. We are made up of doctors, researchers, public health professionals, and traditional medicine practitioners from around the world, which you can see. We've got from Africa to India, the United States, Europe, Canada. It's wonderful to see everybody. Today's webinar is also co-sponsored by the Global Women's Health Network, which are alumni of the Harvard Takemi program in international health. If you would like to keep up with everything that has been happening at Health Together, you have many, many ways. So you will probably see, though, most of our ways still say Maternal Infant Health Canada, and eventually that will change. But and so we have got email, mycancares@gmail.com. We've got our website, which is maa.med.ubc.ca. And there you can actually access all of our previously recorded webinars. If you have managed to miss a few, we've got incredible topics, so feel free to pop over there. We have a Facebook page and a LinkedIn page as well. So we host 6 webinars a year. And if you would like to get on our email or WhatsApp list, then feel free to send your WhatsApp number either in the chat or privately to Dr. Schroff or myself. Or you can email mycancares@gmail.com. We'd love to have your feedback after this webinar. So what we're going to be doing is popping a little survey. It takes like a minute to complete, just to get a little bit of your feedback on what you heard and some ideas for future ones. If you would like to present something, you have some burning, amazing topic you also want to share, feel free to reach out for that as well. As with all of our public webinars, I have to add the following disclaimer. This course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. If you have any questions during the webinar, please write them in the comment chat box at the bottom or side of the screen, depending on what device you're tuning in from. And we will capture those questions and then ask them at the end of the lecture. Discussion is paramount to these webinars. We really, really want you all to be sharing your questions, your comments, and really have a discussion and hearing all of your thoughts. So please don't be shy. The discussions are some of the greatest parts of these webinars. As usual, I'm your moderator, Dr. Emily Solomons. I am a doctor of traditional Chinese medicine and the co-president of the Obstetrical Acupuncture Association, as well as a Health Together cluster lead. I am zooming in from the ancestral and unceded lands of the Coast Salish people. We also have our incredible founder and lead of Health Together, Dr. Farah Shroft, who is also a former Takemi Fellow at Harvard University, who has joined us. Our speaker today, since we don't want to waste any more time, our speaker today is Dr. Hélène Bertrand. She is a clinical instructor at Department of Family Practice at the University of British Columbia. Dr. Bertrand graduated from McGill Medical School in 1965. She worked and did research as a family practitioner until she retired in November 2020. In the last 12 years of her 55-year medical practice, she treated only people referred to her for severe chronic pain using perineural injections of mannitol, dextrose, prolotherapy, lifestyle modifications, hypnosis, and meditation, as well as prescribing corrective orthotics. 80% of those referred found pain relief, which is an incredible percentage. She has published 10 research articles and 1 book on a 2-minute procedure to relieve low back pain. In 2020, Dr. Bertrand actually traveled to Kerala to teach the back pain relieving technique on behalf of Maternal and Infant Health Canada and now Health Together. So we are really excited to hear this next talk, because who knows what will come of that one. So without further ado, I would love to shift all of our focus and attention to Dr. Bertrand. So please, after you.
Hello, everybody. I started to work on orthotics because 30 years ago, I used to love running. And I had sore feet because I was running, because I ran long distances. And a fellow from the Footmax company, which is an orthotics manufacturer, came and said, "Oh, I can make you a free pair of orthotics if you want." And so, hey, I said, sure, I want a free pair of orthotics. So he took out his computer and his pressure board to analyze my gait, and he used his foam containers to put my foot in to check my foot. And then a couple of weeks later, I got a pair of orthotics. I started running and my feet didn't hurt anymore. And I thought, oh boy, I want my patients to have this. So I bought a pressure pad and a computer to analyze the gait, and some foam pads to put in the feet to send them the pressure of the feet. And I started giving them orthotics, and they were all feeling better. And I thought, wow, this is great, except that, of course, they had to pay for the orthotics. And I had quite a few patients who couldn't afford it. And so I thought, okay, I've got to figure out a way to give them orthotics that wouldn't cost them a fortune. And so I'm going to share my screen and show you what I discovered. So this is essentially, I decided that the best way to make orthotics was to use some Kleenex, and duct tape, because that is something that everybody has. And I'll tell you the different parts of the body that I've made orthotics for, and you will see how to make them, why I made them, okay? So essentially, they found, for instance, that if you have a shorter leg, then your whole, when the foot hits the ground, that leg is hitting the ground a lot harder than the other leg. So you're more likely to have pain in your hips. You're more likely to have pain where the hips attach on the pelvic bones, in the sacroiliac joints. And those, by the way, are the joints that are most often and most severely afflicted with low back pain. Why? Because there is no way to see that joint, and people call this joint, pain coming from this joint, non-specific, which means we don't know. And the reason they don't know is because they can't tell how the joint is displaced and by what amount, because they can't see it with medical imaging, and therefore it doesn't exist. So pain in the sacroiliac joints, pain in the hips, if the shorter leg hits the pelvis harder, because it will, that will be one of the reasons. But they found that 6 weeks, this is a Dr. Cameron who wrote the article, And it says shoe orthotics for the treatment of chronic low back pain, a randomized controlled trial. And he showed that 6 weeks of prescription shoe orthotics significantly improved the back pain and the dysfunction compared to people who didn't have any treatment. Wow. Imagine being able to relieve low back pain just because you've lengthened the shorter leg. And the other one that also is interesting is by research by Menes et al. And he says orthotics in soles improve gait symmetry and remove the pain immediately in subjects with mild leg length discrepancy. So essentially, the gait symmetry in the pelvis is reestablished and the pain goes away. Now, there are things that can cause leg length discrepancy that are not normally talked about. One of them is people who have bow legs like this. And the other is people who have knock knees like this. Now, how do you test for bow legs or knock knees? Quite easily. All you have to do is you ask them to put their feet about this far apart, and then you ask them to bend their knees quickly. And you look at in what direction the knees are going. If they go straight, that's fine. But if they go outwards, if one of them particularly goes outwards, you know that's a bow leg. If it goes inwards, you know that leg has knock knees, and it will be shorter than the other leg. And that's going to be the leg you need to lengthen, as well as I'm going to be talking about later, how to correct bow legs and knock knees. Now, the other way to mention, to see which leg is longer, is to have your patient lie down completely straight, and then you put a mark underneath the medial malleolus on both sides, and you see the distance between the marks. If they're not level, then you know that one leg is longer than the other. And you'll know by looking at the distance between the medial malleoli, you'll know exactly by what amount you need to lift up that heel. Now, Hi, this is Hélène Bertrand, and I'd like to tell you how to make orthotics for your patients. The first thing you want to know is, are their legs equal? If they have a shorter leg, then what you need to do is you need to make that leg hit the ground at the same time period as the other leg, which means you're going to have to lengthen that leg by lifting up the heel. Now, of course, you can buy a whole lot of stuff, but the easiest is to just take a piece of tissue, fold it in half, and again, and again. And once you have made this, then you know that you're going to put a pile of these underneath the heel, and that will make the heel hit the ground sooner at the same time or at the same degree of force that your other heel is going to hit. So make a pile of these. I've made a pile of 1, 2, 3, 4, 5 of these folded piece of tissue, and I'm going to put them on the underside of this person's heel so that that leg will become equal to the other one when it comes to hitting the ground with the foot. So now what I do, having piled up my pieces of tissue paper, I'm going to take some duct tape And I hope you all know this kind of tape available. I'm going to take some duct tape and I'm going to cut it. And I will put it on top of this pile of tissue paper and press it down so that they hold good. And then I will put the duct tape around the shoe insert of my patient. Now that immediately means that the leg is going to hit the ground sooner than it would otherwise and with less force because the legs have now become equal. So it's a good idea to make it so that the whole thing holds pretty well. So you're going to, again, put it here and on top of the pile and here. Now you have something that will make that person's leg level with the other one. Now, not everybody has just that much distance between the two leg lengths. It could be that there's this much distance. And at that point, if you made a lift underneath the person's insole that's that high, there's the person's heel would be outside the shoe. And so you have to have something. If you've got a big distance between the two leg lengths, you need to have something that's put by a shoemaker underneath the heel of his shoes. And this is the sort of thing that you can do to add to somebody's leg length if there's a big distance between the legs. And this is quite simple to organize. And because you have measured the distance between the medial malleoli, you know how much distance there needs to be in the orthotic. So hopefully the shoemaker can do that for you. Now, we'll talk about the knees. We were talking about bow legs and knock knees. And a lot of people suffer from pain in their knee. But most people don't check to see whether they have bow legs or knock knees when they have knee pain. And I told you before how to do that. And this is what happens. If you have knock knees, you're going to have a tremendous strain on the medial aspect of the knee. Your medial collateral ligament is going to be very much strained because those ligaments are trying to hold the knee joint together. And on the lateral aspect of the knee, you're going to have bone rubbing on bone, and you're going to get osteoarthritis. So people who have osteoarthritis on the lateral aspect of the knee, watch out, they probably have knock knees. On the other hand, people who have osteoarthritis on the medial side of the knee probably suffer from bow legs and they're going to have pain on the outside of the knee where the lateral collateral ligament attaches, because that ligament is going to be under tremendous strain. Now, there have been quite a few articles on the use of orthotics in helping people who have bow legs, like the effectiveness of orthosis in the treatment of medial knee osteoarthritis. And that's a systematic review. So if you want to see, and essentially they reviewed 34 of 226 papers who'd been written on that subject. And the most beneficial effect came when they customized the orthotics, provided shock elevator, shock absorber, elevated the orthotics, and provided an arch support. Now, I wouldn't think that arch support would be perfectly effective here, because if you do put in an arch support, you're going to worsen the bow leg. But essentially, the insoles that mimicked a barefoot position were the most effective. Now, as I say, if they provide an insole here with an arch support, that may be why there wasn't that much, that good a result. And essentially, there was another article by Shaw, The Effects of Shoe-Worn Insoles on the Biomechanics in People with Knee Osteoarthritis. And that was a systematic review, and they found that lateral wedge insoles invert the ankle and help straighten bow legs. And the effect was much less with an arch support. So essentially, if you've got people with bow legs, you want to put in a lateral insole, not a medial one. And this is, so what you want to do, this is the big toe. You want to put the lift on the lateral side of the foot, and particularly on the lateral side of the heel, because that's where the foot hits the ground. And this is how you do it.
If your patient has bow legs, that means that he has varus knees. And if he has varus knees, then it's because his heel on the outside is turning outwards. And in order to, because think of it, this is a long lever, okay? If the leg turns outward, the knee is going to go out. It's going to be bow legs. So because of that, you need to make the orthotics so that it's going to be turning the knee inwards. And in order to do that, you take a folded piece of Kleenex or tissue paper, and you're going to fold it to make a wedge. And the wedge will go like this and like that. And if it's not big enough, you just add another tissue paper to it. But you make sure that that wedge is going to stay on the outside of the insole that your patient is wearing. So essentially, you make it like this and like that. So now you have a wedge shape. See? So now you're going to put that wedge on the outside of the heel, and that will be pushing the heel inwards because the heel is going outwards too much. Hold the orthotic in place. You're going to put it on the outside of the heel, and you're going to put it so that it is very much higher on the outside than on the inside. So you make sure that you can stick it, and it will be much higher on the outside than on the inside. You see, if you look at the heel now, the lift is on the outside of the heel. And I'm going to put some more duct tape to hold it in place. That way. And I'm going to put some duct tape on both sides of it. And then that way you will have something that prevents the bow legs from causing osteoarthritis of the medial knee. Because if you've got valgus knees, you're going to have pain where the bones are hitting together in the medial knee and where the lateral collateral ligament is being overstretched by the knees going varus.
Now, one thing that people haven't taught us is how the bones of the foot work. Now, remember, for millennia, we were walking barefoot. And the way we adjusted to the irregularities of the ground was by flattening our foot and allowing the bones of the midfoot to flatten the whole foot. You see, at the moment, the bones of the midfoot are together, but if you flatten the foot, they separate. And when they separate, then the foot becomes like a loose bag of bones. And that allows it to fit to the irregularities of the ground. And because your foot fits these irregularities, you know exactly where those irregularities are and what you need to do about it. Now we wear shoes. And because of that, we don't need to have these bones unlocking and fitting, checking for the irregularities of the ground. But we do need the bones to lock together, which is what happens when you move your leg forward when you're about to take off. And those bones, which lock together, form a rigid lever. And that rigid lever is what allows your foot to take off easily. If you were trying to move a loose bag of bones, it would be pulling it off the ground. Whereas if you've got a rigid lever, it's like boom, and your foot goes off the ground easily. Now,
here is the skeleton of a foot. Now, you'll notice that there's quite an arch on the medial side of the foot. And that arch is because there's a ligament called the plantar fascia that goes from this part on the talus and attaches here on the bones that just before the toes. Now, what that does is it causes the bones of the midfoot to be locked together. And that locking is a good thing because when you're taking off, when you're lifting up your foot, the bones are forming a rigid lever, which is easy for the foot to take off the ground. But if you have flat feet, see what happens? The bones are no longer locked together. And at the same time, the metatarsal for the big toe, the hallux, tends to go inwards. And that means if you're wearing shoes, that the shoes are going to push the bones of the toe towards the middle of the foot, and that will give you a bunion. So having a flat foot can be a problem. If you have sore knees and you happen to have flat feet, it could also be because you have a problem with knock knees, because a flat foot will cause the tibia and fibula to go inwards, and that will cause your knees to go towards the middle instead of being nice and straight. So in order to avoid these problems, what you need is you need to make a support for the arch.
Now, arch supports don't just work for flat feet and knock knees. These are what they work most for, but look at all the other problems that can be helped with orthotics. Achilles tendonitis and plantar fasciitis do much better with arch supports because it locks the bones of the midfoot by supporting the arch. Tarsal tunnel syndrome, same thing. Osteoarthritis of the ankle, same thing. Metatarsalgia, and I'll show you how to make orthotics for metatarsalgia. Bunions, of course. Yeah, I showed you how you develop a bunion when you unlock the bones of the midfoot. Morton's neuroma. can be helped with orthotics. Hammer toes can be helped with orthotics. And of course, corns and calluses can be helped with orthotics. So these are all these things that can be helped. Now, this is a healthy looking foot. And if you take an imprint of that foot, that's what it's going to look like. And this is a flat foot. If you take an imprint of that foot, that's what it looks like. Now, I can't sell you a foot pad and a computer to do a gait analysis, but all you have to do is look at the imprint of the foot and you'll have a pretty good idea of what's going on. So essentially, we're going to talk first about plantar fasciitis and Achilles tendonitis. And they are caused by loose midfoot bones. And I was explaining that to you earlier, how a loose midfoot bones will cause a flat foot. Well, a flat foot will overstretch the plantar fascia, and you're going to get plantar fasciitis because where it attaches on the calcaneus is going to be very much pulled on. It's like this is like a bowstring, and this is the bow. And when you flatten the bow, you certainly pull the string. The other thing is that when those bones are unlocked, the Achilles tendon has to pull on this loose bag of bones. It's not got a rigid lever to pull on. So these two tendons are those that will suffer most if you have flat feet. Now, Roos wrote an article where he followed 42 people. And by the way, you can treat flat feet in different ways and plantar fasciitis in different ways. But he decided to check or compare orthoses to treat, like arch supports for the treatment of plantar fasciitis. And he also had people use something that they could wear at night that would move the foot backwards like this and hold it in that position overnight, as if they were standing. And that way, helping to reposition the bones of the midfoot. Well, everybody got better, whether they were orthotics or the cast at night. But the only people who kept wearing the orthotics, the only people who essentially were still using these techniques after a year were those who used the orthotics. They had long ago stopped using the cast that you use at night. So that's an idea that what you can do for plantar fasciitis. Now, the other thing is that the Achilles tendon load in flat feet participants was compared in those who ran. And essentially, the customized arch support and the heel lift caused a reduction in peak Achilles tendon load and loading rate. So essentially, yes, you want to provide an arch support, but if you put a heel lift, then you're shortening the distance that the Achilles tendon has to travel. And so that takes away some of the pain that people have with the Achilles tendon. You see, if you, because the Achilles tendon doesn't have to travel as far when these people are running. So yes, a heel lift will help and an arch support will help. So, and probably if you've got somebody with Achilles tendonitis, you want to do both. I've already shown you how to do a heel lift, and here is how to do an arch support.
A support for the arch will help a lot of problems. And this is how you make it. So you take your patient's insole, and then you take the tissue, and you fold it in half, and you fold it again, and this time you're just going to roll it like so. You roll it, and once you've rolled it, you're going to take another tissue, fold it in half again, and then once again, fold it in half, and then you make it and you put it around the initial one that you've rolled. And the reason is that you are now making an arch with your tissues. Okay, so this one has to be pretty well equal because this is a big foot. And then you're going to make the arch even higher. And by doing this, you're going to fold it again, and fold it again. And then you put it around the two that you've already folded, and you make. Now that is going to be the shape of your arch. It's smaller in the end and it's taller in the middle. And to get the arch at the right place, you find that part here of the person whose foot you're correcting, and you're going to insert your arch fill right here on where their arch is normally should be. And in order to do that, take a piece of duct tape. That's it. Now this, okay, and then you're going to put this arch support. Put the duct tape on the arch support like so, and then you're going to put it so that it will be here underneath the arch of the insole. And by doing that, you're making sure, okay, so this is going underneath the arch of the insole. And so you're going to take another piece of duct tape, put everything together. And like so. Going to glue the two pieces here. And now you see that arch is supported. And if you put the foot on that arch, I need to put a little bit more duct tape on that. Hold everything together. So that's so. Now, every time you make one of these corrections for your patient, make sure they try to walk using it and see how comfortable they are, because sometimes there's too much tissue paper, sometimes there's not enough. And if you want to make sure, just see how comfortable they are wearing this, you see. Now this insole is a little bit big for this foot, but now there's no way you can flatten the foot. If you don't have the arch support, you can easily flatten the foot. But with an arch support, the foot cannot be flattened, it's upheld. And that will help people who have knock-knee, people who have Achilles tendonitis, people who have plantar fasciitis, because all of these depend on a functional arch, a support.
So now we'll talk about metatarsalgia. People with metatarsalgia essentially have pain at the articulation between the metatarsals and the toes. And these often come with women wearing high heels and shoes that are too tight, or runners. Runners will often get metatarsalgia because there's too much strain on these. And essentially, Manico wrote an article showing the effect of metatarsal padding on pain and functionability in metatarsalgia. So you can actually remove the strain on this joint by putting a lift here underneath the metatarsal that prevents these joints from hitting the ground so hard. So this is how you do it.
If you have a patient who suffers from metatarsalgia, meaning there's pain where the metatarsal bones, these guys, are connecting with the toes. If they have pain in those connections where the metatarsal bone, or if they have hammer toes, where one of the metatarsal bones is too low and the muscles pulling out the extensor of the big toe of the toe is pulling too hard, and then you get a hammer toe. Well, if you get hammer toes or metatarsalgia, one thing you can do is fold your orthotic into a triangle and put the triangle right here, just before the metatarsal phalangeal joints occur. So you would put your triangle at this level right here before the metatarsal phalangeal joints. And again, keeping it in place is quite simple. You just take your duct tape and you glue it on top of the shoe insert. That's simple. A triangle, and I put it right here where the metatarsal bones reach the toes, and then I stick it with that tape. And you probably are going to need 2 pieces of that. Big problem, okay? So that way, you're preventing the metatarsal bones from essentially being a source of pain. Just add a little bit of duct tape. I'll just take a little bit of duct tape and put it on, and now I have a problem solved for metatarsalgia. You see the foot, the metatarsal phalangeal joints are now no longer going to be able to go down too much. If you have
Now, another problem that's quite frequent is Morton's neuroma, and that's when the metatarsal heads squish the nerve that's supplying the toes. Generally, is between the 3rd and 4th or the 4th and 5th metatarsals. And unfortunately, runners and women who wear high heels or people who have flat feet are much more likely to have problems with their Morton's neuroma. And this is what has been written about Morton's neuroma. Essentially, the effectiveness of shoe modification and orthotics and the treatment of Morton's neuroma, and that's from an article by Colo et al. And also an article by De Oliveira, the effectiveness of customized insoles for patients with Morton's neuroma. And that was a customized, a randomized controlled double-blind clinical trial. And essentially, it showed that 72 patients with a customized insole and a metatarsal pad and an arch support that relieved their pain and improved their measures of function very, very much, as well as their ability to be active. So this is what you do for Morton's neuroma.
Now, there are other problems that occur at that level, and one of them is called Morton's neuroma. And what is Morton's neuroma? Well, it's when the nerves that supply the toe get squished between two metatarsal phalangeal heads, the third and the fourth, or the fourth and the fifth, usually. So if these are too close together, you want to be able to separate them to liberate the nerve. And in order to do that, the treatment is quite simple. All you have to do is you take another folded Kleenex and you roll it to make a little pad. Now that Kleenex is too big to make for Morton's neuroma. So what you're going to do is you're going to cut off some of that Kleenex and you're going to put a pad between the third and the fourth metatarsal phalangeal joints, right here. And if you do that, you're going to be separating the heads of the metatarsals. Let me stick it together so that you can see what happens. And it's always good to have a metatarsal pad at the same time, which is what we just did. Okay, so now I'm going to take this and I'm going to put this here, and then I will put it here between the third and the fourth metatarsal heads. And right here. And you see now, if I put the foot in, this will separate the metatarsal heads and it will prevent the nerve from getting injured.
So these are all the things that you can do with homemade orthotics. And you've seen how easy it is to make those orthotics. You can actually help low back pain, painful hips, varus knees, valgus knees, knee pain, Achilles tendonitis, plantar fasciitis, flat feet, bunions, hammer toes, calluses, metatarsalgia, and tarsal tunnel syndrome. These are all the things you can do if you want to help your patients.
So these are things you can do to relieve your patients' back pain by making the legs equal, hip pain by realigning the legs, knee pain, again by realigning the legs, and all of that can be made with orthotics. And you can also help all kinds of foot problems, from Achilles tendonitis to pain in the metatarsal phalangeal joints, to Morton's neuroma, to flat foot, to plantar fasciitis. These are all things that you can easily treat with a little bit of duct tape and some tissues.
Okay, so that's it. And hopefully you've learned something today. And I hope that it will be very useful for your patients who suffer. Any questions?
Dr. Bertrand, if I may, I really want to applaud you. I loved the way that you went through everything, and you basically did this approach to like people's medicine, to teaching people about how to take care of their feet. And there are so many people who suffer from foot problems. I really see a huge application here for our colleagues who live in other countries. So I'm really asking like Dr. Andy Ugo, Dr. Henry Lugobe, some of them, what they think for their patients in Nigeria and Uganda and other countries. I see a huge application in Canada as well, because orthotics are so expensive. And I just have a question for you. I'm a yoga teacher, and I've had plantar fasciitis myself. It's a very shockingly common problem amongst yoga teachers. We walk around barefoot a lot, and we probably aren't quite prepared in this day of too many shoes. And so I've had to learn a lot of exercises, yogic exercises to stretch my calves, to loosen up the foot muscles. And that has been very helpful. And so I have to keep doing those. I have flat feet as well as a little bit of a bunion. So all the things you talked about are very applicable to my own feet. And so I wanted to ask you more about the active ways to prevent some of these foot problems that work in conjunction with the ways that you're talking about in terms of creating those orthotic-like structures for the arch and for the bunion and those things.
Well, there's essentially there's two things you can do. You can either stretch your feet or you can exercise your feet. And the best way to exercise your feet is to actually walk barefoot, but not walk barefoot on hard ground. Walk barefoot on uneven ground, because that forces your feet, the muscles of your feet, to constrict. So I would walk barefoot on the lawn or on on gravel, or things that will force your feet to actually work. Because right now we're being held by the plantar fascia. The muscles of our feet are not working as much because we're not walking barefoot. So if you want the muscles of the feet to be working, then walk barefoot on uneven ground. That would be the most important exercise you can do. Stretch exercise, yes, for plantar fasciitis, you can stretch the foot, particularly before you get up in the morning. Stretch your foot so that dorsiflex your foot as much as you can with your hands, so that it will essentially release the plantar fascia. Because if you haven't worn a cast all night to keep your foot dorsiflexed, then your plantar fascia is going to be overstretched when you wake up. So that is one thing that you can certainly do overnight. But there's all kinds of exercises that you can do for the rest of your legs and your butt and your body. And if you want, I can send you a series of podcasts that will teach you how to do those exercises. But that would be an hour in itself, like.
We'd love to have the link to that podcast, because we can post that on our website when we post this. Yes, that would be really helpful. And yeah, and thank you for that walking on uneven surfaces. It just reminds me, I was born in Kenya, and the fastest runners come from Kenya. And I know a lot of them have trained barefoot. And I think that's partly why they're such good runners, because they have such good, so their feet are so strong. Yeah.
Absolutely. Absolutely.
Yeah. Okay, I know lots of other people have questions, so let's let the floor open, Dr. Sol.
Okay, thank you so much it was always, when you speak, it's so fascinating, but it's also so applicable both in kind of low income, low resource settings. So this, I think, is going to be a really fantastic webinar recorded for a lot of our partners in different parts of the world who couldn't, because of timing, tune in today. So thank you so much. We have some questions that have already come up. So there's, I think, first to say that I think Teresa Hayward also had the same sentiment, that she found it very, very applicable, and was very grateful for what you just spoke on. Pegafala asked, I don't know if I said her name correctly. Hi, how much tissue paper should patients wear until it feels more comfortable than before? So I
Okay.
think
That's a very, very important question, because I just showed you how to make the arch supports, for instance. But when you're making an arch support, it could be that somebody needs a much higher arch support, a much lower arch support. If it hurts when they're walking with it, you want to remove some of that tissue paper. If it hurts, if on the other hand, you still see that the foot is flattening too much when they're walking on it, you want to put in more tissue paper. Now, the other thing is that people with plantar fasciitis will often be very, very tender where the plantar fascia is attaching on the calcaneum. And because of that, you don't want the arch support to be there. You want to have a space so that there won't be the arch support hitting that sore spot where the plantar fascia is on the calcaneum. And you can do that in two ways. First of all, you're just going to cut off that part of the arch support that's against the calcaneum. Or you can cut it off and then put a circle. Let me show you. You want to put a circle like that around the area that hurts. You see, so that there will be no pressure on that area. And that, if you do that, then you are going to be helping the people not have pain when they're walking on it, okay? Because the plantar fascia, where it attaches on the calcaneum, can be a very, very tender area. So, as far as the other arch supports, you've got to test it on your patient. You've got to say, okay, now put your feet this far apart and bend your knees quickly and see if the knees are bending straight, you see. Or you can ask them to walk. And this is whenever you're making an orthotic, always, always test your patient before you let them go, okay? Because you want to make sure that they're comfortable with what they have, okay? So make sure that they can walk easily. I personally, I had just recently, I've developed Achilles tendonitis in my right leg. Well, I know my right leg is a little bit shorter than the left. So I've put myself a raise for my heel, and at the same time I increased my arch support, because I know that I want to lock those bones so that my Achilles tendon can work properly. So, but you know, like I was wearing orthotics before because this guy had prescribed them for me.
Wonderful. We have a few more. So there was a couple people who had a similar question, which was would wearing certain types of shoes, which I think you did answer through, but would wearing certain types of shoes like high heels make health problems like bunions worse? And someone else had also said, do tight shoes make it worse?
Oh, yes. When you're buying a pair of shoes, make sure they're comfortable. And you don't want to wear high heels. High heels are bad for everything from your feet to your back. They essentially unbalance your whole body. The only time you want to have a high heel is when one of your legs is shorter than the other. Then you want a high heel on that side.
And
the other thing
not the aesthetic kind of high heel, a practical one.
And the other thing is that the high heel tends to push the toes together, and that tends to, if you've got a bunion, it's going to make your bunion a lot worse. If you've got hammer toes, it's going to make them even worse. If you like, high heels were made to be sexually attractive and very painful.
That sounds about right. We have Dr. Susan Minnick, who said, how can one protect the top and side of the big toe when walking because of pressure and pain causing callus?
The one thing you want to do is buy shoes that have a big toe box. That is terribly important. Now, to protect the top of the toe, you can also buy some felt with with a little hole in it that you can put the top of the toe that's hurting. Put that around the area that's hurting, just like I just showed you how to make something to protect something that's hurting. You want to put pressure on the outside of the area that's hurting. You really do not want to wear high heels.
I know, sad but true. We have one last question, and this is from Dr. Andy Ugo. Please, do these methods apply to those who feel pain under the feet, especially for tall people?
It applies to all people who have pain under their feet, especially for heavy people, because people who are heavy are putting a lot more pressure on their feet. The other thing is that some people have a condition called hypermobility. And these people who are hypermobile will get more pain because that means if they're hypermobile, that means the ligaments that surround their joints are overly loose. And if they're overly loose, the nerves inside those ligaments are overly stretched. And when nerves inside ligaments are overly stretched, they don't like it. And because of that, you can, like people who have, who are heavy, or people who have hypermobile joints will have more pain. That is a guarantee. And that's why one of the treatments for painful feet is a weight loss diet. And the way to lose weight is, well, okay, I'm 81 years old and I've been on a low carbohydrate diet for the last 31 years. And I haven't had any weight problems.
Well, I have to say, I know we've come to our hour. Thank you so much. This has been such an incredible webinar once again. The information is very practical and useful, and I think that this is going to be well utilized around the world. I'd also like to say a big thank you to our webinar and social media team for all of their organizing and promoting of the event. And to, of course, the fabulous Healthy Seminars for donating their platform to host us once again. It's always just so wonderful to have a team that comes from everywhere and all supporting, and for everybody to join in. I know that for some people it's very early in the morning, and for others it's very late. So thank you to everybody for tuning in. And yeah, and thank you so much, Dr. Bertrand. It's always a pleasure.
It was a real pleasure working with you, Emily, and I hope everybody here gets information that will be useful to them. We'll see you again at some later date.
Okay, thank you, everybody.
Bye-bye.